Hi everyone, this is Dr. Gilead Show. I want to welcome you back today on Dr. Gilead Show, Thursday, June 2017. The year is gone halfway already. So we are on Facebook Live and WBGR Radio. Today we're going to talk about opiate use disorder, opiates, general, a lot of them. But I want to quickly say that please do not use what you hear on this platform to make a diagnosis of yourself or a family one, a loved one. Do not treat yourself based on what you hear on this platform. And also, it's always good to consult a trained personnel who can make the appropriate diagnosis and treat you properly. Dr. Gilead Show, the producers, our guests, and the host cannot be held responsible for what anybody does based on what they hear on this platform. So please get appropriate diagnosis and treatment so that you can do well and feel better. Today on Dr. Gilead Show we have a special guest. My special guest is Dr. Tedesi. Dr. Tedesi, you're welcome to the show.
Thank you, Dr. Oswala.
Please tell our audience who you are, a little bit about yourself. Go ahead.
Yes, my name is Brooke Tedesa, and it's really a pleasure to be here and be part of this information and awareness program. And I am a mental health specialist and addiction disorder specialist. And we always discuss this issue as a concern to our community and also the number of loved ones who have been affected by this epidemic. So it is also a very challenging endeavor, but we can't give up. And my clinic also deals with these kinds of challenge. Usually we find it coupled with other underlying emotional or psychological conditions. So we'll be looking forward to continue working on this.
All right, good. So you have a PhD, right?
I have a clinical psychology degree, which is called PsyD.
So that is a Doctor of Science.
Psychology.
Doctor of Psychology. So, yeah, and Dr. Tedesi has a clinic. It's called Family Health Clinic, and he sees a lot of people with substance abuse, and that's why he's one of the best brains to be on this show today. I want to welcome you again to the show. Thank you very much.
Sure.
All right. So we're talking about opiate use disorders. Now, opiates are a class of drugs that are derived from opium, which is the opium plant, or also it could be chemically made to compounds that are similar to those products from opium. These opioids include the legal prescriptions for pain, like painkillers, oxycodone, which is the same thing as OxyContin, hydrocodone, morphine, fentanyl, and of course the big one, heroin. The other ones are legal and are prescribed by doctors, but heroin is illegal. Now, Dr. Tedesi, you see a lot of people with substance abuse addictions to opiates. I know they tell you some of the names, they call them on the streets. What do they call them on the streets, if you remember?
Usually the pills are usually called the pills.
The pills,
yeah.
Yes.
But if they kind of modify that and the type of way they administer it, then they have it a street name. But the recent concern we have is mostly with pill addiction,
Yes.
which is prescription pain medication. And usually people start from having some kind of physical pain, and then they develop tolerance and develop dependency. And that is when things start out of control.
Right. So you know, from your experience, most of them get addicted to this from prescriptions from the doctors.
Yes. Unlike 30 years ago, people usually do heroin by injecting it or snorting it, which is always was also a choice of drug for a lot of people at the time.
Yes.
And we call it the heroin galleries, where people join together and kind of have it a social type of high that they get out of it, which of course that way caused a lot of people to contract disease of
Big time.
Yeah, and because of that, there was movement to even at one time to provide needles, and as a way to control contamination. But the recent ones are younger people these days who are inflicted with this pill addiction, and it is sort of in a naive way because they're so desensitized about taking pills from early young, and families they keep pills in the cabinet and they see them using them for different reasons. So when they're approached by friends and they want to try this, they're not going to be scared or threatened by it. So they want to try it once, and once they try it, and I have a case that I'm working on now, that he just tried it for sake of experimenting, and then he started seeking for that drug.
Wow.
And after that, he had to go and buy it. He had to go out of his area and find ways in the middle of the night, and caused a lot of family dissent and confusion, and also his life started to go, and eventually he became a collateral for a legal problem.
And you know, that is the usual story.
Yeah.
That is the usual story. I was looking at how, you know, I see a lot of people with substance abuse too. I was looking at how they call like the pills. They call them Oxys, Perks, Vicks on the streets, and all kinds of names. But also like the heroin, they call all kinds of names. And the essence of this is for people to understand when the family member is talking about some things, you need to know what they're talking about. The plain heroin, sometimes they call smack, junk, black tar, horse, all kinds of names. So you must be aware of what these things are called on the streets, so that when your loved one, your son or daughter, or even your spouse starts doing things like this and they're talking on the telephone, using some names, you must be aware that they are going off track. Dr. Sades, I was looking at, yeah, go ahead, you wanted to say something?
Well, usually the recent problem is people most of the time, they conceal this drug.
Yeah.
The pills are easy to carry around. The pill is easy to use it any place, any time. But once they're addicted, they have no control on to pick places or to monitor their safety, or even whether they're going to be exposed or not.
Right.
And that is where the progression of the addiction is. And usually, what is the telltale sign for parents?
We're going to get to that.
Okay. Right.
So the question is, most of the heroin used in the U.S., where do these things come from? Who brings them in?
Well, the street heroin usually come from far places.
From like Afghanistan?
Like from Afghanistan,
and
even it could come from South America.
South America, through Mexico.
Through Mexico.
It's a huge...
It's a huge industry.
Yes.
And so it has always been a struggle to prevent drug distribution or through different means, and yet we haven't made any dent on that. So when one type of drug dries or goes out of fashion, then there will be another one that comes. And the prominent one is, of course, now still we're dealing with opioid dependency.
Yes, yes.
Yeah.
And you know, I see a lot of people. So when doctors prescribe these medications, the people you see, do you ever ask them how do you use it? Do you inject? How do most people use?
It's amazing, Dr. Swallow. Most of them, they start with either themselves getting it from a doctor for a legitimate reason.
Yes.
And then from there, it is up to the individual. That individual could be either become physically dependent or may have also psychological underlying things.
Right.
Then it become managing that emotion or that distress or whatever problem that they may have. And that will lead them to use it, not for medical reason for the pain, but it's also become for psychological reasons. That is one way. The other ones are, they may have a friend or a partner or a spouse who also have legitimate reason and acquired it that way. Then it goes from one friend to another friend, and that has become the source and the beginning of for most people.
So usually, do they tell you how they use it, whether they inject it, like these pills? Because I saw someone and he said, OxyContin, he crushes it, mixes it with water, and injects it.
Injected,
It's
yeah.
unbelievable.
It is how, when they reach a point of extreme craving for the
Yes.
drug, in the digestive system way is not going to be as effective. So they're trying to devise a different way, effective way of administering it quickly into the bloodstream, and that is where the injection comes. Sometimes also they crush it and snort it.
Yes.
And that is also a quick way that goes to the bloodstream, to the brain. And the more they do that, the more the addiction becomes stronger, and looking and seeking for more and even stronger drug. After that, they're not really treating anything. They're only treating their addiction.
The addiction.
And which leads into overdosing.
Yes, all the problems.
And
we're gonna get to
we're
that
gonna get
because
to
it's unbelievable. You know, recently I can count of at least 5 or 6 people that have died. Yes.
People that you know.
Yes. And you know what happens? One of my patients was telling me yesterday, when someone dies, everyone runs to the dealer that sold him the drug.
It's amazing how classic it is.
Yes.
And that's what it used to be in the 60s and the 70s. Even though I wasn't into the field at that time, from what people told me when they were at that time, that's what they do. And I think the mind is no more rational at the time. So the only thinking about what is the best high I can get.
Yes.
So I don't care if it kills me.
Or
maybe that person didn't know how to do it right.
Exactly.
But
or whatever killed this guy must be the real deal. He will get me real high with small amount of money.
Yeah.
It's unbelievable. I looked at the prevalence, how common it is, and we had it says 0.37% of adults in the U.S. 18 years and above have opioid use disorder.
Oh,
that is yes,
staggering.
That is a staggering number. And the male-female ratio is, of course, more males use drugs than females, even though the trend is changing a lot. For pain medications, 1.5 to 1 male-female ratio, but when it comes to heroin, about 3 to 1 ratio to males. So more males will use heroin more than females. Now, there was this statistic. It says in 2015, 2 million people had substance abuse use from prescription medication. 2 million. That is staggering.
Yeah, and we're talking about also how many families are affected. How much community is devastated by that.
Yeah, and once one person is affected, it drags into the family relations, financial, all kinds of things. But we'll talk more about how. Yeah. Now, but also, what the amazing thing is that opiate use, both the prescription pills and heroin, is much, much lower in African Americans than the other races.
Exactly.
Is that your observation in your clinic?
Yeah, in my clinic, I have 2 clinics. One is in Montgomery County and one is in here in Prince George's County. And we serve a good number of people. And the majority of the people we find that have the addiction for opiate, and particularly they start with the pill, the Oxycontin, Percocet, and similar type of opioids. The women are the one that I find mostly they quickly become habituated and addicted to it, and then they are the one who become overdosed, and they are the one who possibly die with no one knowing where they were, and if they're lucky, they'll be found by either individuals or police or EMT will come and save them.
Right.
But this in Lower County, we don't see that many African American into that, as opposed to what it used to be in the 70s.
Right.
Yeah. So there's a different type of drug is appealing at this time in this community.
And I have a vast population of patients. So you have people come to see me from Charles County, Howard County, and all those places.
Yes.
So it's unbelievable what is going on. I think we have a caller there.
Oh.
Hello.
Oh, hey, Dr. Swallow.
Hello. Who do I have the pleasure of speaking with today?
Barry Chan.
Oh, hey, brother Champ. How are you?
I'm good, man. I'm good.
All right. Thank you for calling in. Today we're talking about heroin and pain pills addiction. You have a question or you have a contribution? What you got for us today?
Maybe a contribution
Okay, go ahead, sir.
on heroin. That drug, heroin, it's been around for a decade.
Mm.
There used to be a pain medicine back in the 1800s called laudanum. But now it's been purified and it's dangerous. It's dangerous.
Very dangerous, man.
You know, it's so highly addicted, be it mental and body or and physical. So it's a dangerous drug, and it should be made more aware and more education on it.
Yes. So what would you tell our young people? What advice would you have for our young people?
Yeah, I tell the young people, don't be posting and doing drugs, period. You know, you got a life in front of you. And, you know, either life through hell or life through God.
Mm.
It's just as simple as that. I mean, the kids nowadays look for release on life because times are hard on them. I would just tell the kids, hey, you know, it's up to your responsibility to make life good.
Absolutely.
And stay away from the drugs.
So you said parents are hard on them. So what would you tell the parents? Not just to say anything to the kids?
Okay, no, I didn't say the parents were hard on them. I said life is hard on them.
Oh, life is hard. Yes, absolutely.
Yeah, life is hard on them. You know, their parents struggle, you know, and, you know, they see this and they just, you know, they just take on their environment and what they're in. Although, you know, you have people with money that does the same, and I believe those people with money that does the same, you just being just defined as their parents. But in the black neighborhood, you know, in at-risk neighborhoods,
Right.
you know, this drug or any type of drug
Mm-hmm.
is appealing to the kids because a lot of people around in the neighborhoods using it, and they think that is a part of life. So, you know, just understand the power of that you can't get out of the neighborhoods that you're living in, you know, by education,
Right.
willingness, and strength. You know, able to make better life for you and your family.
Right. Thank you very much. And one of the statistics I just found out that heroin, opiates, the number of African Americans using it is very minimal compared to the other races. So, I mean, it's a good news for us, but we still need to continue to talk to our young ones and our adults as well. I want to say, yeah, go ahead.
Well, I mean, you know, living on stats is, you know, is always uneven because you have more population of, you know, I guess I'll be blunt. You have more population than, you know, white people than you do of black people.
Right.
You know, or people that's minorities, so to speak, and that's why they call them minorities, because basically, you know, the population of the country, you know, is more heavily on the white people versus the you know, I'm trying to think of the word, by the minority.
Right.
Okay.
Okay.
So hanging on stats, you know, it's probably not good because, you know, the majority is the majority. You know, any percentage that they do drugs are always going to be, by stats
You're
rather than,
right.
by minority.
You're absolutely right. Yeah, and that's one of the reasons why we're doing this program, to inform as many people as possible to stay away from, just create an awareness so people will know the problems that can occur when you delve into drugs like this, just to educate our young ones, our families. And I think is reaching out to as many people as possible. I really want to say thank you for calling in today. Barry is a good friend of Dr. Gilead's show. Thank you very much.
All right, take care.
Thanks, Barry. Okay, God bless you, brother.
All right.
Bye-bye. So, yeah, so the caller obviously was talking about how this is ravaging our society. And of course, he advised our young people, do not touch drugs, because it's going to kill you, man. It's going to destroy the whole family.
Yeah, it's amazing. That is where actually the awareness should start.
Yes.
And we talk to our children, or the young ones, family talk to the children in a very open manner. The parents have to be also well educated and informed about the different kind of drugs that are circulating around, and the kind of problem and the damage that is causing, so that they will be having a communication based on awareness and facts and information.
Right.
So children will be listening and also appreciating what the parents are telling them, not as parent talking down to them or telling them that don't do this, you can't do that. Let's just make it like a friendly discussion. Type of, which really more effective than being hand-off or by being excessively controlling.
Yes, absolutely. And the painful thing is when someone dies, it affects the whole family. In 2015, there were 54,000 deaths from overdose, and this was more from opioids. But this year, when the statistic comes out this year, 2017, I'm sure it's going to triple. Already half of the year, I personally, I know many that have died. And the painful thing is this. I have two patients two girls doing well, clean for years. One even got the children back because the social services took away the son. And she did well, got a job, got her son back. She went back and did it one time.
That's all it takes.
And the friends, when she was becoming too sleepy, they put her in the car and left her there, and she was found dead the next day in the car.
Wow.
And it's happening. So it is going to be really, when the statistic comes out this year, I think it's going to be very, very touching. So people should really know this and stay away from it. So the question is, how does opioid or heroin or pain pills, how do they work? So these medications, they go to the body, to the brain, and they block pain sensations. That way they bring pain relief. Now, but the other part of it, it could also bring some good feeling, some euphoria, and relaxation. And in some people who, doctor, some people have anxiety disorder. So once they take something like this, it calms them down. And so these good use of it, because of the euphoria, the relaxation, could make them begin to misuse and use extra.
Exactly. Yeah.
So, but the other question, I don't know if you have an answer to this, is why would 2 people get prescribed a pain medication, and one has no need for it, takes it, it relieves the pain, and they don't ever use it anymore, while another person gets hooked to it.
Yeah.
So
those are the mystery, and sometimes we have theories about that.
Yes.
But any person who claims that I don't like it, I don't want to use it, but if that person says, or I won't be addicted, if that person use opioid again and again, he will be physically addicted. Yeah, there's no running away out of that. But some people are prone to addiction.
So there's some genetic component?
Some emotional, psychological predisposition.
Okay.
Yeah. The genetic factor for me is possibly insignificant. It could be there. because some may come from families who have history of addiction or some sort of psychological disorder.
Mm-hmm.
Yeah. So, and when the healing process and the recovery also varies from person to person.
Yes.
And that is also provided what type of services are made available and how timely the person also is receiving treatment, and how much the person also have a support system that would encourage him to recover from the addiction. So that treatment aspect is another topic.
Yes, we're gonna get there.
Mm-hmm.
So the people you see in your clinic, how do you test if they are addicted to opiates or if they are high using that? What are the tests that you do?
When they come to see us, most of the time, 99%, they don't come high.
Okay.
They try to be in a better position or shape. So you cannot dictate any kind of
By just looking at
by
them.
looking at them.
Yes.
There are times you may see, but they may have withdrawal. Then you can see them being fidgety. They're probably sniffing or sweating, or the bodies. Then if they already been diagnosed with that habit or disorder, then we're gonna focus on that and we ask them and we take it from there. So that would be.
Do you do any toxicologies?
The other part is we do toxicology test, which is by way of a drug urine analysis.
So you take their urine?
Yeah, on the spot we can determine if the person has ingested or not ingested. That's a telltale sign, but sometimes it may not be conclusive, and we may have to send it to the lab for confirmation.
Okay.
But the tricky part is this kind of drug, I guess, have the lifespan of, I think you know better than
the half-life is usually, once you take it, half-life in the body, maybe 5 hours, 6 hours.
Right.
Now, but you can still detect it about 2 to 3 days.
3 days, yes. Yeah.
And in the urine, and sometimes for people who use it a lot, sometimes you may pick up some metabolites up to 7 days.
Mm-hmm.
But the greatest one is a hair follicle. Take a
that would
hair,
give you
can get it for 3 months.
3 months, yeah.
So these days, like, sometimes I tell somebody, you're looking for a job and you're still doing drugs. Say, oh, well, don't worry, man. Well, if they're going to pay me, I'll stay clean for 30 days.
Yeah,
should be
stop for 3-4 days.
Yeah. But what people don't know is you go, most places, they take a hair follicle and they test it. 90 days, the heroin or the opiate could still be found.
Yeah, can trace
So,
back.
so you can really find it.
Yeah. Mm-hmm.
Now, how we make the diagnosis of opiate use disorder is actually from the DSM-5.
Yeah.
And there are classical criteria that are met before you can say someone has opiate use disorder. And so, for example, someone who was prescribed some opiate pain medications, and they begin to take more and more.
Right.
So once they're taking heavy amounts or taking it for a longer period of time that it was intended to, they're having a disorder. That is one criteria.
One criteria.
Yes.
Right.
And the other ones are things like persistent, their desire. They want to do it all the time.
Yeah.
And they also they make efforts every day. They want to stop. I know some people come to you, you say, hey, why are you using? And they say, well, I want to stop. But still, they are using it.
Yeah. Well, I have to, because if I stop, I can have this withdrawal that could be painful. And of course, they are right. Withdrawal from opiate can be very critical,
Yes.
dangerous, unless it is done in a medical setting,
Yes.
supervised by professionals or
Yes.
clinicians. So that is one thing, and because they may not have access to go to a treatment or a hospital or a clinic to get that taken care. So if the person motivated to really stop using the drug, then we will find ways on how to connect that person with communities programs or treatments that will facilitate that. If the person, after we've done that, is not keeping his appointment or not going and following through, then obviously the person is not motivated. He's more preferred to use the drug, or he's heavily addicted. So there would be hard work. But on top of that, the person may not even come to the outpatient clinic and drops out. And that is when we worry that person possibly now is in big trouble.
Right.
Who knows what has happened?
Mm.
Yeah.
So the you know the other criteria are like spending a lot of time in activities trying to get a drug, or even using or recovering from the effect of the opioids. And also, some people have a strong craving, strong desire to use it, even when they don't want to use, but the craving is there. They just cannot stop thinking about it. The other criteria, things like using in a fashion that results in failure to fulfill major obligations, work, school, family obligations. I'm sure you see a lot of people who.
That is the most obvious things that would start to take place, not if not right away, and sooner or later will be you'll see those symptoms or signs, and a lot of time people who are actually working and using this drug, which they call themselves quote unquote functional addicts.
Yes.
Actually, they think by using the drug responsibly, they think they are functioning and can perform, but that is really superficial, because if you ask the loved ones or the work performance,
yes,
it's not going to be as expected, so it's a matter of time that all that alibi is going to be exposed. Yeah.
And some people, it's also known that they give up or they reduce important social and occupational or recreational activities, things that they used to do before. A normal family person goes to work, or maybe church, or recreation, sports. They don't do any of that anymore.
It's amazing. I'll give you one example of one of my patients who, because of the addiction, it was maybe Thanksgiving night where family are getting together and they're trying to celebrate. He finds an excuse, claiming that his friend calls him, he has a car breakdown, and he gets up from the middle of the Thanksgiving dinner and goes all the way down to DC Southeast to get his drug.
Right.
And then when he told them, he said, "I'll be right back down the street." And then he never come back. And then he calls them and says, "I'm staying over my friend," and parents don't know what's goes on. And this repeatedly happens, and the family could not really pinpoint, losing weight, irregular behavior,
right.
Sleeping all day, not taking any responsibility. All those things are symptomatic of the addiction. Yeah.
And also there are some who they even though they know that they have a problem, but they still continue to use. They have physical problems, they have some psychological problems from the use. They just cannot stop. And others develop tolerance and also withdrawal symptoms. So once these things are happening, it is obvious that this person has a opioid dependent disorder. Well, I see Gloria Tokes. Thank you for joining. Fola, both are nurse practitioners, big in psychiatry. I see Ms. Yolade and Joseph and Ms. Cookie from Nigeria. All these people from all over the world calling in. Thank you very much for tuning in. Today we're talking about opiate use disorder. But please don't go away. We're going to take a short break, and we'll come back in a minute. Stay with us. So low. The volume is low.
It's low.
From that. Should have another one back.
On your mic or the?
Don't worry, don't worry. Yeah.
Are we on break?
We're still live though.
Yeah. Okay.
Representative in order to order online, so you can order online and have the shipped directly to you. All you have to do is log on to www.opiateusedisorders.com youravon.com/2blessed. That's www.youravon.com, the number 2blessed. Happy shopping and enjoy your products.
You ready?
Yes.
Okay.
All right. Welcome back to Dr. Gilead Show. Today we're talking about opiate use disorder, and that is heroin plus the prescription pills. We are on Facebook Live, Dr. Theo Osoala, MD, and we are also on WBGR Radio. You can call on 301-429-9247, 301-429-9247. And my special guest today is Dr. Tedesi. He is a specialist addiction counselor. He has his private practice here in Hyattsville, Maryland. Dr. Tedesi, the symptoms of opioid intoxication, when people are really intoxicated with opioids, what do you see if you have really seen somebody intoxicated?
Intoxicated. It is rarely that I encounter them.
Encounter them
When
intoxicated.
they're actually at that level.
Yes.
Yeah. Either I see them the next day or much later.
Much later.
And by then they have already calmed down.
Calm down.
And probably experiencing some
Withdrawal.
Exactly.
We got to the
yeah.
withdrawals.
Yeah.
But you know, like when people are intoxicated, the euphoria, the excessive happiness of opioids, but also this medication is so sedating. You know, I used to be in the faculty as clinical assistant professor at University of Maryland, and there in Baltimore, there's a market there. You go by the market, you see people nodding, and they're going that way. They're standing and sleeping.
Yeah.
But the irony is they never fall. They never fall.
They never fall.
They never fall. They're standing and they're nodding, and you say, what is going on with this person? And I have taken some young people to that market to see. Take a look at what people who are addicted to drugs, what they're going through. And it was an eye-opener for a lot of them.
Yeah.
So, but also some of the effect is it causes a decrease in anxiety, and it gives them this sense of tranquility, this sense of calmness, and also no pain, some form of indifference to pain. You see someone has, I tell you this, I have a patient who injects, and all his veins are gone. In course of trying to inject heroin, he hit an artery. So he hit an artery, and the artery that supplies the 3 fingers here. And when he came to me, these 3 fingers were all dead, black.
No blood circulation.
No blood circulation,
Yeah.
gangrenous.
Yeah.
And I said, man, what? He wasn't even feeling the pain. And I asked him, have you gone to hospital? Oh, no, I haven't gone. Are you kidding me?
And not only that, it's amazing that he just focused on his heart.
Yeah.
Usually most addicts who do inject, they would find places in their body or part of the body that they couldn't find any.
Right.
So they would do it in many places.
I have seen people inject in their jugular here.
Yeah.
It's unbelievable how much people do to get it
that
high.
extent.
Yes.
Okay, hold on one
So some, you know, they get delirious. Some have had coma and severe intoxication and died. So is intoxication or is very, very dangerous.
Very
People have died. And you know, recently they mix it up with fentanyl. Fentanyl is the killer. But anyway, we will come back to that. We have a caller on the line. Hello.
Oh, yes. Hi, Dr. Osoala.
Hi. Oh, hey, Mr. Lover. How are you?
I am good.
Okay, thank you. What, you have a contribution or you have a question for us today?
I actually have a question.
Go ahead, please.
So I recently came across another medication, Vivitrol, which is naltrexone, that is also being used for opioid addiction,
Yes.
as well as for alcohol treatment.
Absolutely.
So I was wondering what advantage does that have over other opioid medications such as Suboxone and methadone.
Methadone.
If you're familiar with that.
Absolutely. Yeah, so Vivitrol, which is not naloxone, naltrexone, sorry, is one of those new combinations which is used to treat both opioid addiction as well as alcohol. Now, what it does actually, it reduces the cravings. The craving is a major thing that pushes people to want to use. Now, most people don't want to really do heroin anymore or pain pills, but because the center in the brain, the opioid center in the brain, keeps asking for this medication or for this substance. So they have severe craving. Is worse, for example, when they pass by where they used to get high, or when they see a friend they used to get high together, the craving is so much. And I tell people, whatever you love to do, even when you quit, the experience is still there. So naltrexone decreases that craving, which makes it a very vital part of the treatment modality for opiate use. Now, but we cannot say it has, it may have some advantage over things like Suboxone or methadone, but Suboxone on its own, what Suboxone does, because Suboxone is a partial, it's an antagonist and also a partial agonist, and that means it takes over the opioid receptor sites. Everyone's brain has a receptor site, a part of the brain where when you do heroin or you do oxycodone or oxycontin, any of those opioid pain medications, there is a center in the brain where it attaches. There it gives the good feeling, it gives the euphoria, it blocks the pain. Now, what happens is Suboxone, which is a combination of buprenorphine and naltrexone, and naloxone, excuse me, will go and block that site. So the good feeling people get from doing opiates is gone. Even if you do the opiates, you're not going to feel good anymore. The euphoria is gone. So there's really no use to do it. So in combination, they all have their advantages. But I think from my experience with patients with opioid addiction, still, the Suboxone is much better than naltrexone. So that's why it's been recommended as one of the major treatment modality for opiate addiction. And we do a lot of that in our office. So I would advocate for Suboxone anytime, but also there's nothing wrong in that combination with Vivitrol. But Vivitrol much better for alcohol use disorder.
Okay.
Yeah. Thank you so much for
it is the only one that comes in injection form
right.
for now.
Yeah, Vivitrol is the only one that comes in injectables for now. But also we have naltrexone tablets that come in 50 milligram pills, and it helps a lot of people as well. But for ease of compliance, Vivitrol is what is advocated, but it's so expensive. But hey, if the insurance pays for it, why not do it?
Okay.
Yeah.
All
right. Thank you very much.
So much.
Thank you for calling in. Thank you for tuning in all the time.
Okay.
I think we have another caller too. Yeah.
WBGR. Okay, hold on 1 second.
Hello.
Hello, Dr. Sola. This is Chukuma Esoga.
Oh, yeah, hi.
From Silver Spring.
Hey, hi, Chuck. How are you?
I'm doing fine.
Thank you for calling in. Today we're talking about...
I had a question.
Yes.
With the topic today on heroin use disorder.
Yes.
I was wondering, like with other addictions such as alcohol addiction and marijuana addiction, whereby there are like medications that are used to like wean the user of this dangerous substance. Is there a kind of similar medication for heroin use?
Okay. Yeah, we were just talking about, the other caller just asked similar questions. We were talking about there are medications that have been approved for treatment of opioid use. And the one really that is magical is the naltrexone, which comes as Narcan. What happens is when people use too much opiates, their respiration can be stopped. They have a respiratory depression, they stop breathing, and they can die. But
Okay.
we have Narcan, which you can spray into the nostrils. Once you spray it in, it's magical. The person wakes up right away. But that is for immediate use when someone is in respiratory depression. Now, but also for long-term treatment, we have things like Suboxone, which is naltrexone, and which is naloxone and buprenorphine. It's a combination. So
Okay.
we also have Subutex, which is buprenorphine alone. There's also Zubsolv. These are all combinations of buprenorphine and naloxone, which we use on a regular basis to help people reduce the craving, and also it helps them to block the receptor site where when people take opiates, whether heroin or the tablets or the opiate pain killers, they don't get any good feeling from it. So it really it helps them reduce the drive to go do opiates. So there are medications that we use, and we're going to talk about those shortly.
Okay, I guess that leads up to a follow-up question that I have.
Yes.
What are the possibilities of weaning a person off one drug and then getting them addicted on another one?
Well, that is one common question that comes to me all the time. As a psychiatrist, and also for Dr. Teresa, who a psychologist, as addiction counselor, we get this question all the time. And we see that in things like methadone. You see someone who was doing heroin and they get addicted to it, they get on methadone program. In methadone program, they're given methadone, and some people get high on methadone.
Yeah.
So the thing is this. When you're on methadone, you get something legally, one. You're not injecting. That avoids all the complications that can come from IV drug use, sharing needle, contracting HIV, hepatitis C, and also infection, because these people don't really clean the skin properly before they put the IV needle.
Yeah.
So they can get infection in the heart valves, and also they all kinds of problems that can come with IV drug use. So that solves that problem. But of course, it's also difficult to get off things like methadone. But most people have done well on things like methadone as well as Suboxone. It's just the need or the desire to quit doing illegal drugs. And a lot of people have done well. But I know that we're working on a whole lot of other ways of getting off these substances. Research is going on with INH and also other programs sponsored by SAMHSA to know the ways of getting off these addictive medications. So a lot of work is being done, and we hope that soon there will be less addictive medications to treat opiate addictions and other addictions in general.
Okay. Thank you very much, Doctor. Keep up the good work.
Okay, thank you. Thank you so much. Thank you. Anything you want to say about what it really...
Yeah, the treatment, the medical aspect of the treatment, which is very critical and essential, that addresses the physiological and the medical. And the other part is the psychosocial.
Yes.
Where a lot of work and the long-term work requires. And usually to allow the person to understand their own addiction and the cause of their addiction, the impact it has, and then how recovery takes place, and then how to maintain recovery, what is required, and what kind of program and treatment modality is effective. A lot of time people have problem committing to that or having availability. So the relapse is very frequent, and also the recovery is shorter for most people because of that. So the intensified treatment should be in the psychosocial area,
Yes.
where they get psychological therapy, addiction therapy, relapse prevention techniques and methods, and reorganizing their life and their lifestyle. And usually, people, if they commit to those in the long term, of course, those who do, they eventually will have control on their addiction, and then they commit themselves also in a support group or support self-help program that is known to be helpful, the 12-step program. So this is like a lifelong work for an addict to work on recovery. And it's very hard to say 1%, I have finished now my work on my recovery.
Right.
It is it's a continuous and lifelong work.
Yeah, because
And
once you lay your guards down, you get addicted
get
again.
addicted. And
Yeah.
anything can come to throw you off your track, and it comes in a different shape and form or angle. It doesn't repeat itself the same way.
Right.
And that is why the challenge of addiction for addicts is cumbersome. And we sympathize, as therapists and those professionals, we sympathize with addicts. And it's not no one that prefers to be addicted
Yes.
and destroy his life or her
Right.
life, yeah.
Yeah, and this is one of the main reasons why we're doing this show, so people can really understand what is going on. And when I go to the market, I forgot what this market is called in Baltimore, you see a lot of people, their speech is so slurred when they are intoxicated with opiates or heroin. They have slurred speech. They have what we call pinpoint pupils, and their pupils are so tiny, so tiny. And if you look, for families, you need to look at when your family members are taking off their clothes, you may see track marks all over. You can also see you will see change in behavior. Sometimes they have altered temperature regulation. And I remember one of the musicians, a celebrity that died recently, not recently, a long time ago. One of the things he was telling his doctor who was treating him in his house was, I feel hot and I feel cold. That is classical of opiate intoxication. So the temperature regulation is messed up because of the part of the brain that helps to regulate temperature has been affected by the drugs that this person was given. Now, withdrawal symptoms are also very common. I'm just going to run through these. They become very dysphoric, they become sad, and sometimes they have muscle ache, a lot of, they have diarrhea, tears coming from their eyes, and sweating, and some people are yawning all the time.
Yeah,
like
feverish kind
feverish,
of
yes.
sneezing, sniffling.
Yes, they're sneezing a lot.
Aches all over.
Aches and pains all over.
And then we think that they have fever, and we're trying to treat them with fever medication.
Yes.
Which is not the case.
Which is not the case. So these are all the things. And once family members see these things, you must be alerted, you must go get them help. Now, I know Dr. Teresa was already talking about psychological treatment. So you talked about group therapy, individual therapy. In these therapy sessions, what do you do? For example, someone who is addicted to heroin comes to you for individual therapy. What exactly do you do?
Well, the initial point is when we see them for initial interview.
Okay.
That initial interview is the development of the psychosocial history of the person, and then what family he's come from, how he was raised, where he went to school, what kind of social life he has, when he first experimented with drug or alcohol, and what age is that. The common age that I run into is people experiment with marijuana and alcohol,
Right.
even age 12 or even 13, even sometimes in some cases at age 9.
Wow.
Okay, that would tell you if a child is exposed to any mood and mind altering chemical at that age.
At age
it is-
9, oh
yeah,
my
then
God.
they will be open to experiment with
Anything.
stronger drugs.
Yes.
And that historical fact of the individual has to be well compiled. If they are telling you fully and completely and honestly, then you can come to a very accurate diagnosis. And then we will try to formulate a diagnosis based on which one is a primary disorder, or if there is also an underlying emotional psychological problem, which is, it could be anxiety, depression, or even some trauma that usually some of them experience, all variety of trauma as an adolescent or as especially women, young girls. And even though they don't indulge into heavy drugs, the girls usually, or the young women usually indulge into drinking alcohol, and then they quickly move into heavy drug. Yeah, or they develop other addictive behavior that is just equally as painful and damaging. So then the treatment will be, it is best to do an individual therapy initially.
Okay.
To best know the degree and extent of the person's disorder, and then after the person is stabilized and understand about what treatment is all about, how treatment works, what the goals are, then we can set them into a group setting where they share their experience and learn from one another and become actually the best modality for drug addiction.
So what of group therapy? What is
Yeah. The modality that...
Yeah, what is the, how does group therapy help these people?
Right. The group helps is because most people come into that group believing and admitting they have addiction, and they have lost control on their life, and they need change, and they don't know which way and how to start. So there would be people who are on the recovery, gone some distance. There are some who just started. There are some already have managed to recover and maintain it. So this combination of people will share, exchange information, and suggest ideas and support one another, learn from one another. And that will be a forum where they feel comfortable of having some type of brotherhood or sisterhood, where they learn from one another, from almost the same experience, and that is found to be effective. But that doesn't mean everybody is going to be successful. There are individual situations where people either drop out or probably need more treatment than just the drug group counseling. They may need psychiatric intervention.
Right.
And that is when you come in and you do a very amazing work in making sure that they get medications that not interfere with their other addictive choice of drug.
Right.
Yeah.
So, we're almost out of time, but if a family member comes to you and says, my son is doing drugs, or you want to advise people generally, what would you tell family members to look out for to make sure they catch their family members or they get them early enough?
Yeah. The best thing is for families to know their children very well and their routines, their associations, their friends, the type of activities that they are interested in. That is knowing their children to the micro level. They have to. Otherwise, you lose them. Then if you know them then when that routine changes, when those social association changes, then that is a telltale sign which they don't have to be boldly intervene instead of denying or justifying it. So that is one thing. And then they're staying up late, or they sleep all day, or they cut classes, or they don't account and they need more money, or things are missing around the house, and all this kind of behavior, and they sometimes even bring in their own drug into their house and stay home. So my child is at home, and so it's safe. I'm okay. But no, you have to feel that if something unusual happens, you have to thoroughly examine their room and see in their drawers and anything that it's not being privacy invasion. It is really preventing the disaster that may ensue.
I have a son, and he knows that I can pee him anytime. So he comes in, I say, hey man, I need your pee right now. He says, what? I don't do nothing. I say, yeah, I need your pee. And I've always checked him. He's been clean, but that is me, because I'm a physician, I'm a psychiatrist, but not many parents have that ability to do that.
Yeah.
But I think sometimes if anyone knows that, hey, my family member, my father, my mother is going to pee me or check on me, or they know that they can find some of these drugs in their bags, school bags or something, they're not going to do it. So it's like what you said, it's always good to search their school bags, search their rooms, and that will make them, hey, be aware that anytime someone is going to check on me.
Yeah.
So and it's a good routine. It's a good practice to be close to your family members as well.
Yeah.
So for you, for people who have already done drugs, what is the advice you have for them?
To seek treatment as immediate as possible. Always early intervention and timely treatment saves lives and resources. That is the motto of my clinic. And they can call my office at 301-779-2461, or they can go to the website www.fhccenter.com.
So www.FHC, that's Family Health Clinic,
Center, yeah.
Family Health Center,
Yeah.
FHC,
FH Center.
FHCenter.
Yeah, .com.
.com.
Yeah.
So, I'll tell you what, Dr. Teresa is someone that I know, and I know he treats a lot of people with substance abuse. You can call him. What is the phone number again? Let our audience know.
The number is 301
301
779
yes
2461.
2461 779 2461. Give him a call. You will get the best service you can imagine. So I really want to thank you for coming to the show today.
Sure, Dr.
We appreciate you.
It's a pleasure and be part of helping
Yes,
the community.
yes, and this is all we can do to help our people. Thank you very much. I also want to thank all those that joined: Gloria, Falah, Yabo, Miss Cookie, Joseph, Chuck, and Ralph. Ralph is an attorney from all the way. Well, thank you. And also Barbosa joined. Thank you very much. And all those who are following us on Facebook, thank you very much for joining. Stay tuned. We're going to meet you at the same time next week, Thursday, at 1 p.m. on Dr. Gilead Show. Thank you very much for tuning in. We'll see you again next week. Bye-bye.